Hello, and thank you everybody for joining us. I'm just going to hold off on our introduction for just a couple of seconds here. I'll let some more people enter the webinar here as we kick off tonight's meeting and tonight's presentation by Dr. Wong. So I'll go ahead and give everybody just a couple more seconds to join in, and then we'll go ahead and start this thing off. All right, everybody. Well, thank you so much for everybody for attending tonight's webinar. My name is Michael York. I'll kind of be your moderator this evening. Tonight, we're lucky enough to have Dr. Elaine Wang speaking a little bit about glaucoma emergencies, an awesome and interesting topic that I'm sure everybody will enjoy. If you have any question during tonight's webinar, please don't hesitate to use the question and the Q&A function down below on your Zoom toolbar. We'll go ahead and get to all those questions at the end of the webinar, just in case if you have a question earlier on, Dr. Wong might go ahead and address that in the during her presentation. So please do feel free to go ahead and use that question and answer toolbar, and we'll be sure to get to your questions as we go along. Giving tonight's presentation, like I mentioned, is Dr. Elaine Wang, who is a board certified ophthalmologist who specializes in glaucoma and cataracts. A little bit of background about Dr. Wang: she received her undergrad degree from the University of Rochester and then received her medical degree from Duke University School of Medicine. While at Duke, she was elected to Alpha Omega Alpha, which is one of the most prestigious nationally recognized medical honor societies in the country. After that, Dr. Wong completed her internship at Harbor UCLA Medical Center, and then her ophthalmology residency at the prestigious Stein Institute at UCLA. After her residency, Dr. Wong completed her glaucoma fellowship at the, once again, renowned Bascom-Palmer Eye Institute. There's a theme throughout these, all very good academic places for Dr. Wong. And that was at the University of Miami for the Bascom-Palmer Eye Institute. And now, after giving a little bit of background, I will pass tonight's presentation on to the speaker of the hour, Dr. Wong.
Thank you, Michael, for that very nice introduction. And I'd like to thank everyone for taking the time tonight on a Wednesday night to attend our webinar. And I'll be talking about some emergency situations in glaucoma, in specifically probably specific types of glaucoma that brought on more of an urgency and emergency to have it treated right away, aside from our bread and butter open angle glaucoma. So that's right, there are different types of glaucoma, which we will talk about in the rest of the talk. So I like to always start my talk with what glaucoma is, because I love it so much. That's why I choose it as my specialty. It is the leading cause of blindness for people over 60 years old worldwide. And people may think cataract is, actually it is, but it's a reversible cause of blindness worldwide would have been cataract. And for those of my patients and you that's attending this webinar who has had cataract surgery already, you know you had cataract. After that's removed by surgery, you see a whole lot better. That's what we meant by saying the blindness from cataracts are reversible. Taking the surgery can solve the problem. However, glaucoma is the opposite of that. Damage from glaucoma, or for many of you, you may understand that as high eye pressure, is irreversible. So it's not that we're trying to scare you, you got to take your drops, do the laser, proceed with the surgery. It is a fact that any damage, that any visual field loss or vision loss you give to glaucoma is not something we can reverse. So that's why we always emphasize a prevention and early detection and go on with appropriate treatment. Just to give you a little bit more of objective data, in 2010, so about 12 years ago, or I should say 11 years ago, 2.7 million of people in the United States were estimated had glaucoma at that time by the National Eye Institute. And now 2030, which is only a short 9 years from now, 20 years after the 2010 data, that number almost doubled to 4.3 million. And it's projected to continue to grow to 6.3 million in another 20 years from 2030. So we're definitely getting more and more glaucoma in our society, especially because aging is becoming a problem, and glaucoma is known to be an aging problem. As in, the older you get, the risk of you having glaucoma is much higher. And we all live much longer now thanks to our much improved living standard and medical intervention. But the more we live, the more risk we also carry in having a lot of the things kind of, wear and tear, including your optic nerve. The wear and tear of the optic nerve translates to glaucoma. This is to show you a normal anatomy of an eye. We're basically looking at the eye from a side view and cut in half. The top part, you can follow my cursor here where it says cornea, is the transparent part of the eye. And behind that, this where it's labeled iris, is the darker colored part of our eye. Here we may have blue eyes, green eyes, hazelnut eyes, brown eyes, but that's the color part of the eye. It's called the iris. Where these two structures meet, where the cornea meets the iris, is the drainage angle. And that's where draining of fluid inside the eye happens. And that's basically where disease happens for glaucoma. When you have a draining problem, I like to think of it as a plumbing system of the eye. If there is clogging in the plumbing system, or if the piping isn't working in this whole drainage system, then pressure can build up from a backup of fluid. So that's where glaucoma happens, in the front of the eye, where draining outside, things from inside going outside becomes a problem, can cause something to wear and tear, which is the optic nerve. And that, in this photo, is much better illustrated, where you could see if the drainage angle is blocked, nothing is going through this channel system between the cornea and the iris, then the pressure really translates from the front part of the eye all the way to the back of the eye, where the nerve meets the back end of the eyeball and translates to pressure onto this nerve bundle. I tell my patients the nerve bundle literally works as an electrical cable. Think of the eye system, the system the eye works as very similar to a computer system. The front of the eye, or the eyeball itself, is like the monitor. And your brain is similar to the computer main tower of the computer. And that nerve is a connection electrical cable between the two. You could have a perfect eye and a perfect brain, but if the signal isn't going through between the two parts, you don't really see well. And that's what glaucoma hurts, which is this nerve connection cable. It does that by having damage from high pressure in the eye. So essentially, glaucoma is an issue that happens in the front, but affects the back of the eye. And what you end up having is that this nerve, now we're looking at it on the left side as side view, it's a cross section. Basically, these arrows is trying to illustrate pressure from the front of the eye exerting onto these nerve bundles. There are nerve fibers, millions of them literally, bundled it up into this optic nerve. And when that happens, you can see front view of the nerve here on the right side of your screen, where the nerve is losing its function by losing this pink area. If we look at the nerve from a cross-sectional view, like what we're doing right now, straight on, but take a cut of it, you're basically looking at a structure that's similar to a donut. The donut has a big rim and a big hole in the center. And the hole is where vessels come in from the back of the eye into the inside of the eye to provide nutrition for the structures. And the donut rim is actually the healthy nerve tissue. That's the bundle I'm talking about. When you have a lot of pressure pushing on this, it's essentially making these nerve bundles thin out faster and faster, which basically it's equivalent to having this hole in the middle becoming bigger and bigger. So that's when you hear your doctors may say your cupping look worse, or if they say your nerve looks damaged, your nerve looks thinner, that's what they mean when your glaucoma is getting worse. Basically, your healthy nerve tissue is replacing by space, or that big hole in the center. And that's all from pressure from the front of the eye. And what happens when these nerve bundles become a problem is you start to have blind spots in the vision. This is to show if you happen to have a vision, blind spot in the center of your vision in this arc way. And the picture on the right is trying to show, and in advanced stages, these blind spots can really get much bigger and bigger. And also you're experiencing a tunnel vision where your peripheral vision is restricting and coming to the center. And that's why we do, when you come to our clinic for your glaucoma follow-up, we do the visual field. That's the one you sit in the machine, they give you the flashing lights, you click on the button. That's the visual field or field of vision test. That's basically to map out whether you have this tunnel vision, losing peripheral vision, or if you have any blind spots in your vision at all. That would help us to decide yes or no you have glaucoma, if you're a suspect or the beginning stages, or two, whether your glaucoma is stable or getting worse. So like I said at the beginning of the talk, there are actually multiple types of glaucoma. Most of us are more familiar with the primary open angle glaucoma, where the angle, which is equivalent of the drainage angle I showed you earlier, is open. So that I tell my patients in my clinic, that's equivalent of saying the piping system that lines the plumbing system in your eye is the right caliber. It's the normal average caliber, just like everyone else. However, the pump in that system isn't working quite adequately. That's why we call it open angle, but the water is still not going through adequately, hence you get high pressure and glaucoma. There are other types of glaucoma, and I'd like to just say briefly that glaucoma suspect basically means we have enough suspicion or you carry enough risk factors to develop glaucoma along your lifetime. You may not have it right now. Some other physician may refer that to, borderline glaucoma, beginning of glaucoma, or things like that. But what they're saying is it's worth monitoring you for a period of time, long term, to make sure you don't develop glaucoma, or if you did, we're catching it early to prevent as much irreversible vision loss as possible. Now, between these two, there are other types of glaucoma. One is called the narrow angle glaucoma, and secondary glaucoma, as in glaucoma caused by other diseases of the eye or of the body, which we'll go through one by one. And these two are the problems that are the types of glaucoma that may present as a real emergency. The narrow angle, just to give you a brief summary of that, is as opposed to having the right caliber in your piping system, it's the pipe in the plumbing system is actually born to be very narrow to start with. So analogy to show that is if your piping is not wide as a pipe, but as narrow as a straw, trying to get through a little straw, a lot of water isn't going to work very well. So things will definitely back up and cause high pressure problem. And that's where the glaucoma emergency come from. So acute angle closure attack is a real emergency of the eye. It's almost as bad as a full-blown retinal detachment or a severe infection of the eye. It's considered one of the main real, very, very emergent situations when it comes to the eye. So just to show you again what I showed you earlier, the angle is the cornea meets the iris, the color part of the eye, and this little area right here between the two structure is the angle where it says drainage angle here. Some people can have very narrow area in this drainage angle, and that's why you may have blockage and have high pressure rise in a very short period of time. This one shows that really, really well. On the left side, where it says, open angle, cornea, iris angle is open. So if this person, probably this is actually trying to show this is a normal eye, but if this person were to have glaucoma, it would have been the open angle type. In contrary to that, just as a comparison, you can see the iris and cornea space right here is almost non-existing. So there is no space. The angle is closed, and this can cause a really high eye pressure in a very short period of time and cause very, very significant irreversible blindness, actually, or vision loss. So it's an urgent, acute angle closure attack is an urgent but uncommon event. It's a dramatic event where people would experience super painful eye. It won't be something like, I think I had a pain in my eye once in a while. It just happened 5 minutes ago and it's happening again. It wouldn't be that. It would be my eye is in so much pain that no one would miss it. I've never had this pain before and it's constant giving me this throbbing pain. You may even have a headache, and also to a point that you may start to have nausea and vomiting as a result of this pain. So it's not something you need to think about whether you have it. It's something you have it. And at the same time, people may mention that your eye is very, very red and your vision becomes very, very blurry. And if you look at a light at that time, you may see a rainbow halo around that light. And it doesn't happen commonly in both eyes at the same time. It usually happens one eye at a time. And it tends to happen towards the end of the day when you're sitting in a semi-dark room, which will actually induce dilation of your pupil on its own. It's a natural dilation because your pupil is trying to open up to allow more sunlight coming in, or light coming in general, and that would actually cause more of a crowding problem in that angle. So sometimes people may even realize your pupil is somewhat dilated, but you have very bad blurry vision and pain. And that's a result of a dramatically increased eye pressure in a short period of time. Like I said, the vision will be significant damage. I have seen someone, my own patients, having an acute attack like this and went from a 20/20 vision to hand motion. And I have seen people with these repeated episodes and went into blindness altogether. So all these damages, not only it's severe, more importantly, it's not reversible. So if left untreated, it can eventually lead to cost you your complete vision. And if we don't identify that, not only we're missing the chance of saving your vision, it could also convert to an intermittent, but also a chronic form, which is less acute, but almost equivalently damaging to your vision. So like I said, I like to repeat the symptoms for acute angle closure attack. I don't want to scare you that you may sit in the house and get one of these attacks out of the blue. You don't. I'll talk about risk factors and who are more likely to get it than others in just a few slides. But if you have the diagnosis of narrow angle, which your doctor will mention to you, then you're one of those people who might get into an acute attack. If you have open angle glaucoma, you're less likely to get into an attack like this, almost impossible for you to get into this unless the angle becomes more and more narrow over time due to other things, which we will also touch on later. So just to refresh our memory, what I said recently, symptoms related to acute angle closure attack would be halos around lights, usually it's a rainbow halo, aching eye or brow pain, bad headache, throbbing, dull, achy-like pain. You may have even nausea, vomiting due to the high pressure in the eye. Your vision will be significantly reduced, and people will comment on the redness of your eye, or you could see it. The vessels on the surface of the eye will be pretty engorged. Now, you go to a doctor when this happens, and what would they found during an acute angle closure attack? They will find your vision drops. If they check your vision on the chart, it'll be very foggy vision and you probably drop more than a few lines. You will have extremely high eye pressure. IOP stands for intraocular pressure or eye pressure. 10 to 21 is the common understanding of normal eye pressure for normal people who don't have glaucoma. But if it's above 21, it's considered high. And based on my experience with my patients, if you go into an acute angle closure attack, your pressure is more than likely to be more than double this number. Recently, I've seen a couple of patients in these kind of attack for multiple different reasons, but their pressure were all in the 40s, 50s, or even 60s. Your cornea will be pretty swollen, and that's from the high pressure. And like I said, the surface vessels on your eye will be very engorged, makes your eye appear red. And your pupil will look like they're dilated, but they don't really react to lights anymore because they're in shock in this high pressure situation. And we also use this little mirror shown here on this photo. A lot of my patients might heard me say or see me using these mirrors on your eye to look at your angle, especially at the first time when I meet you. I want to know if you're open angle or narrow angle. I have to use this mirror to look at the hidden angle. And if your doctor use your this gonio mirror to look at your eye, when you have one of these episodes, they will find that the angle is completely closed. So risk factors. We find these strong association between the following factors and having an acute angle closure attack, which make females 2 times more likely to get it than males. If you're extremely farsighted or otherwise known as hyperopia, this basically means that farsighted people are more likely to have a smaller eye altogether compared to people who are nearsighted or myopic or normal eye vision. The space inside the eye is just very crowded to start with because we have less territory to work with. Therefore, the anterior chamber or the space between the cornea and the iris is just much smaller in these patients. And so if you start with the smaller essay, then you're going to lose more of the space eventually. And like I said, the chamber, which is another way of saying the anterior angle, is pretty shallow. And if you have had a previous attack in one of your eyes, then the second eye has a 50% chance of getting it during your lifetime if nothing is done to prevent it. Another strong association is your ethnicity. Asian people in California, there's a pretty high prevalence of Asian ethnicity here. So that's definitely the highest rate reported. So in Asian countries, in China, acute angle closure or angle closure glaucoma is their predominant form of glaucoma. In our country, in the United States, open angle glaucoma is the predominant form. But if you happen to be Asian, you live in California, you're farsighted, female, and those are all increasing risk factors for you. There are some weaker associated factors that we found as well. Advanced age. As we get older, the size of the lens inside the eye or the cataract itself swells in size. So we understand cataract as a clouding of the lens inside of the eye. In fact, in addition to having the lens being more cloudy, it also swells inside. So I tell my patient that imagine the lens being an M&M chocolate shape. With time and the cataract develops, this M&M chocolate is going to swell and becoming more of the size of a baseball or a basketball. So that shape. So that will take up more space in the eye and push everything forward and backwards. So with that, your angle may continue to become more and more small with age. So that's why aging is another thing. Family history, anything can be pretty much attributed to genetics nowadays. Open angle glaucoma is known with identified genes that it's basically genetic, inherited. Angle closure glaucoma is less associated to family history compared to open angle glaucoma, but we also definitely find evidence. So it's more of a fact that if your family look all similar, you look like your parents or grandparents. So if they had shorter eyes to start with, you may have shorter eyes. So that kind of association. And another thing is a lot of you guys call me about certain medications that you're put on by your primary care doctor or other healthcare providers, because all those bottles have a warning sign and says, do not take this medication if you have glaucoma. They're not specific or as specific as they could be. If you have open angle glaucoma, you do not have to worry about these warnings, because what they talk about is that these medications can cause certain structures inside the eye to swell. And again, you see the theme is if something else inside the eye, this very fine, nice, small space is taking up more space, something else needs to give up space, which is the angle. So if you're put on some certain medications for seizure, sulfa-containing drops, or for psychiatric disorders, it may cause swelling inside the eye that also pushes everything forward to cause an acute angle closure attack. So that's what you need to worry about, especially if you have angle closure or narrow angle to start with. But not everyone is at risk of developing a glaucoma from just taking these medications. So why does it happen? Like I was alluding to, angle closure can be primary. What it means is that you're born with smaller eyes, you're born with smaller piping, smaller space in the angle, you're more likely to get an attack just because the way you're born with. Secondary to another eye disease or drug induced, we basically touched upon those. The secondary to other eye disease, we will talk about later on a different topic, but it also is something else you get in the eye. It could be from the cornea, it could be from the retina that's leading to a narrow angle. So like a thick cataract, for example, we talked about an M&M chocolate swells up more like a ball shape, causing the lens moving forward, stealing space from the angle. Or neovascularization, or otherwise known unhealthy vessels growing in the eye from some retina issues like diabetic retinopathy or ischemic syndrome of the eye, or even tumors. Those can cause secondary closure of the angle and acute angle closure attacks. And certain, like I said, sulfa medications or anxiety seizure medications can cause that as well. But it doesn't happen usually. Even if you're taking these medication and you happen to have narrow angle, you don't necessarily go into an acute angle closure attack, because the swelling is kind of unpredictable. It's not that if you take it, you'll definitely get an eye structure swelling, but just more of a precaution to remind you this could happen. If you notice any abnormality of your vision after taking the drops, make sure you see a healthcare provider or an eye doctor to be specific. How does it happen? We kind of already alluded to this earlier. It happens when the space between the iris and the cornea becomes smaller. So the acute angle closure attack happens when this kind of closure happens all in a sudden, out of the blue. So that we would call that an acute attack. And I also mentioned that this could transfer into a chronic form, which is something in the eye, not always, but intermittently. For example, the movement of the lens pushes the iris forward to touch the cornea from time to time. Maybe the first couple of times it doesn't really do any consequences, but if they do this touching enough of times, a lot of the times the eye may form a scar from at the side where this iris touched the cornea. So more and more scars form. It's almost like a zipper. You're zipping the angle closed altogether over a long period of time and cause a angle closure in a chronic form. And this is actually more common compared to an acute attack where your pressure goes from a 10 like normal to a 70. The chronic intermittent attack will cause your pressure to go up slowly. So you may not experience those dramatic side effects or vision or pain changes that I was talking about at the beginning, but over a long period of time, 5 years, 10 years, decades, then you may end up actually having a chronically closed angle with your pressure creeping up slowly from the teens to the 20s to 30s. And because our body is so good at adapting to these small changes, you may not even notice pain or anything in your eye as the chronic angle closure develops over a long period of time. So the exact mechanism is, if you have two things touching, it's either something's pushing the thing in the front back, or it's something that's pushing something at the back to the front. So basically, that iris can be pushed forward to touch the cornea. Like we talked about a large cataract or a tumor at the back of the eye. Those are physical, mechanical things that pushes the iris forward and causes angle closure. But there are other things that could pull the iris from the back towards the front, such like an inflammatory membrane that forms during an inflammation episode. Some of you might have had jingles or shingles in your eye, and that's considered one of the uveitis or inflammation in the front of the eye. Others may just have uveitis, and that basically is a fancy way of saying you have inflammatory conditions inside the eye. And repeated inflammatory conditions can form the scar tissue that can pull the iris towards the front. And old vessel, chronic vascularization from diabetic retinopathy or other things also causes scar tissue, and that scar tissue is pulling the iris forward to close up the angle as well. There's a special diagnosis of ICE syndrome, which is a ICE. It's an acronym, stands for iridocorneal endothelial syndrome. And this syndrome basically is very, very rare. It happens only pretty much in middle-aged women. So I wouldn't worry too much about that diagnosis unless you're specifically being told. Uveitis and neovascularization are definitely way more common than this one. So what to do? If you are determined, if your doctor determined that your angle is narrow, in order to prevent you from going into one of these severe attack episodes, we need to do something emergently. So I like to tell my patient, what I do is to create an emergency exit on the iris. That's the dark part of the eye, the color part of the eye. I like to put a little hole in that iris through laser. It's an office procedure. And that hole will act as a backup pathway for fluid to escape in the event that something causes your angle to be closed completely. So we're not left trapped inside a confined room with no window to escape. We do have that little hole that will alleviate some of the problem. It does not solve the problem. Whatever's pushing the iris forward or pulling the iris forward is still there. The hole only acts as an emergency where it doesn't allow your pressure to go from 10 to 70. It probably would only go up to 30 and give us more time to deal with the situation more permanently. So if you're advised that you need this emergency exit strategy or laser PI, peripheral iridectomy, that's to prevent you from getting into a very drastic angle closure attack. And this is a picture to illustrate what happens. Basically, what we do is we're looking at the eye from top down. Here is the cornea. This is the iris, and this is the lens or the cataract sitting at the back. Laser goes in to poke a little hole on the iris. And if you look at it straight on, this is the cornea. This is the blue eye with the blue iris. You see that's trying to show you a hole on the very edges of the iris. No one could see it. It's so tiny, measured in millimeters, that I would also need to use magnification to find it, to make sure it's still there, to allow it to act as an emergency exit. And this is a real life picture of one of my patients where you could see a hole on the iris. That's the emergency exit. We may put it on the top, we may put it on the side as well. Either way, it shouldn't affect your vision. It's there to prevent you from permanent vision loss. So other options we need to use, or treatment we need to use should you unfortunately go into one of these acute attacks, would include obviously eye drops. We pour all the eye drops we have available into your eye. We use it a lot and we use it frequently to try to get your pressure down as soon as possible. Usually, or I would say 100% of the time, based on my experience, it's far from enough. So we use oral medications to help reduce the eye pressure as well. Now, oral medications are only emergency tools we use to lower eye pressure. If we put you on oral medications for a very long period of time, it damages your kidney and liver. Sometimes it can, I shouldn't say it's for certain, especially if you have kidney issues or liver issues. So that's not a routine practice. So you don't hear me say, if the eye drops don't work, let's do some pills. It's only used in emergency situations. So we use oral medications, sometimes even have to tap into IV medication to reduce your eye pressure within a shorter period of time. Once we control the pressure to a more allowable range, then that allows the cornea to be less swollen and the eye less inflamed. And we can do the laser we talked about to alleviate some of the pressure in addition to that. But taking out the cataract, if the cataract is still in the eye, is the ultimate solution if that's the reason to push the iris forward. So those are the things that we do in that order: drops first, pills, then IV. Once we control the situation to a more acceptable stage, we do a laser. And once your eye's more quiet, we take out the cataract to allow more space in the eye. So we do this in this order, but still moving in a pretty timely manner. Usually these happens within days. So I recently did a cataract extraction in someone who's in their 50s, very early for cataract surgery in general, but it was very much needed because her pressure was in the 60s. And even with medication that she takes by mouth and all the drops that we could give her, and with the laser that's already done, her pressure was still in the 50s. So we had to take out what's causing the issue, which is the ginormous lens in her eye, because she had a shorter eye to start with. So we took out the lens, and now her pressure is in the low teens without any drops. Unfortunately, she presented to my clinic way too late. And at that point, she already lost a lot of vision. But she does subjectively tell me that even though she's only seeing some fingers, counting fingers in her face, but she's seeing definitely more of those after the surgery. I wish we can identify the problem way earlier, then we could save her more vision. But the more important part in that situation is to address the other eye to prevent that eye from getting into an attack like that. If it's the chronic situation we're talking about, then obviously we do eye drops. And because in chronic situations, I did tell you that it doesn't really drastically increase your eye pressure overnight. It's more of a creeping up of pressure over time. So the eye's pretty in a calm and quiet state despite the slightly higher pressure. We then just go into cataract surgery without having to deal with the oral medication, the IV medication, or the laser. A lot of you guys who have narrow angles might have heard me saying you do need a cataract surgery, rather sooner than later, because it's what's causing the angle to be narrow. So at the time, I also tell them, you have this opportunity for me to look around after the cataract is out to see if there's any scarring between the iris and the cornea. And if so, I'll attempt to use a tiny forceps to peel that apart. That being said, the peeling is our good attempt in trying to solve the scarring problem, but our body is naturally so good at healing any wound we create. So even when I open up the wound, over time, it may actually grow back again. So that is not a guarantee that the scars will be completely lysed or opened, but it's a good attempt, and it works about 50-50% of the time. So early cataract surgery definitely is the permanent or the more definitive solution to a chronic angle closure problem. And if that's still not enough, which can, because a lot of the times we don't really have our eyes checked since we were, 40 years old every year, routinely, religiously, we may have decades of this chronic angle closure happening, and over time it has already caused a permanent damage to the drainage angle and to the optic nerve in the form of glaucoma. So in those cases, despite our best effort in taking out the cataract and lysing the scar tissue, you may still have high pressure. That's after the cataract surgery. So in those cases, we will have to do glaucoma surgery, the more invasive one. For those who listened to my previous talk, when I talked about the minimally invasive glaucoma procedures, I did mention that it's actually a limited selection for narrow angle patients, because we don't really have the angle to work with. The angle is the area where MIGS procedures are performed. So if you have those issues, we have to go with the more invasive glaucoma surgery, the real cutting surgeries, like I say, to put an implant in or create another pathway for the water and fluid to escape the eye, to lower pressure that way. So just to emphasize, cataract surgery is definitely a good solution for angle closure glaucoma, because it's probably the structure that takes up the most space in the eye, if you think about it. The cataract is like an M&M chocolate when it's young. As it gets older, it swells into more of a ball shape. Now, taking that ginormous cataract out and put a very thin piece of plastic of lens implant in the eye, that will definitely give back the eye a lot of space for it to distribute to other structure in the eye, including the angle. So a lot of clinical studies have shown that just taking out the cataract itself without doing any MIGS, without doing glaucoma surgery, can reduce eye pressure. And that's especially true for people who are already struggling with a space issue inside the eye, like those who have narrow angle or angle closure glaucoma. So basically, this is trying to summarize: if you have shorter eyes and narrow angle, the taking out the cataract is to uncrowd your eye and give the eye more space to work with, to allow more fluid drainage. So if I mention to you, or of your doctors mention to you, your cataract is not too bad, but I like to recommend taking them out because of this narrow angle problem, we're not trying to push for a surgery to happen. We're really trying to solve the problem at its root cause before it causes more damage. So the narrow angle glaucoma we talked about. It behaves differently than the open angle. So, I hope I drilled this into your mind. If you have the narrow angle glaucoma, open up the narrowness is the only way to go about this. And drops do not open up the narrowness. It helps to manage the symptom. The ultimate solution is to give more space back to the eye by taking out the ginormous cataract that you already have in your eye. And just to show you how we peel the scar, this is a picture of the surgery we do. You see how the iris here, where the red arrow is pointing, it's kind of creeping up compared to over here. There's more space here, but this one is pulled up. That closed up the angle. That's where the angle is. And this picture shows the iris at the root, kind of touches the cornea. This space is the cornea. this is the iris, that's the angle, and you see how the iris root is really touching the cornea. And on the other side of the picture, we peeled it open, and this triangle area, this angle is definitely more open. So that's the goniosynechiolysis, or using forceps to peel up the scar, peel open the scar that I referred to after your cataract surgery. So it's very efficient, it's safe. It only takes me a couple of minutes at the end of the cataract surgery, but it can work if it's working. It's worth a try. But like I said, it's not a promise. It's a 50-50 chance. So now we're going to change gears and go into the other type of glaucoma that I talked about earlier, is the neovascular glaucoma, which happens a lot in patients with severe diabetic problems of the eye, who's got vein occlusions, or those who may have tumor in their eyes. So it's a result of high eye pressure. I should say the high eye pressure in this type of glaucoma is as a result of the unhealthy vessels. And neovascularization is just a way of describing unhealthy new vessels growing in the eye. It's associated with severe diabetic retinopathy. You may hear your doctor say PDR, which stands for proliferative diabetic retinopathy. I think Dr. Dute on her last talk talked about diabetic changes, so that's relevant to glaucoma as well. This diabetic retinopathy can cause retinal bleeding, retinal swelling, and in severe cases, the scarring of these problems can cause retinal detachment. And that's why you're getting all those lasers and injections in your eye if you happen to belong to that category. So these unhealthy vessels not only grow on the retina, even though it is a retina problem, it's called retinopathy, it can actually grow all over the place in the eye, including the iris as well as the angle. So this is to show you your iris should not look like this. That purple arrow shows you the unhealthy vessels that grows on the top of the iris. They're not supposed to be there. In this area where you don't see much vessel, that's normal iris. And in this area with all the red lines illustrating the vessels, it's unhealthy blood vessels that should not be there. And these can cause scarring, pulling of the iris towards the angle, and cause angle closure as well. So exactly like what the title says, the scarring of the unhealthy vessels in the angle and iris can cause close of the angle. And the angle becomes dysfunctional over time and does not drain out fluid adequately. Even if I have definitely seen in some of these severe diabetic retinopathy patients, the angle looks like it's open, the space is there. But because of previous vessel growth and all the repeated growing, regressing, scarring of these vessels, even though the space is there, it's not working. It's losing its function. So it's not draining out fluid adequately, and that will lead to pressure buildup and nerve damage and glaucoma, which is known as the neovascular glaucoma, or NVG. This is to show you that I showed you a picture earlier where the vessel could grow on the iris surface. This is another picture where the fat white arrow is pointing at the pink area in the angle, and that's the unhealthy vessel in the angle growing, potentially causing chronic scarring and closure of the angle over time. So these people often present with very high pressure again. I actually recently saw, I would say, a handful of these people, which is, I don't know if it's what we drink in the water or something. The neovascular glaucoma is definitely becoming more obvious in our clinic recently. And I'm seeing several with pressures in the 40s and 50s. It's very difficult to control with just eye drops alone. I never, almost ever, were able to control their pressure just by giving them drops alone. Oftentimes, like the acute angle closure attack episodes, they will need temporary oral pills for pressure control. And it's almost inevitable that they will need surgery. Real glaucoma cutting surgery. MIGS procedure is not relevant in this group of people. They don't have a functional angle for me to do the MIGS procedure. We do cutting surgeries for these patients for pressure control. So it's almost management-wise similar to an acute angle closure emergency. And in fact, it is an emergency because the pressure is so high, double what's normal, despite our best effort with the drops. If we don't lower the eye pressure as soon as we can, vision is definitely going south. Risk factors for people to develop neovascular glaucoma is proliferative diabetic retinopathy, vein occlusions, tumors, or ocular ischemic syndrome. If you happen to have diabetes, I hope you are getting regular checks of your diabetes and pressure or retina health during your diabetic screening exams with the eye doctors to make sure your diabetes is not causing problem of your eye. And if you had a vein occlusion or blocked vessel or bleeding in the eye, those are some of the things that the doctors could refer to when they talk about vein occlusions. You are at risk of developing this specific type of glaucoma and should be screened for that, which we do every time you come back for the follow-up. So sometimes people may be confused why I'm repeatedly coming back every month, every 2 months for you to check what? My pressure look okay. Yes, the pressure may look okay, but your eye is still at risk of developing these unhealthy vessels, which may cost you a lot of vision along the chronic long term. So how do we treat that? The key to treat neovascular glaucoma is to treat the unhealthy vessels. High eye pressure is a symptom or a problem associated with these unhealthy vessels that originates from a problem you have on your retina. So it requires hand-in-hand collaboration between the retina specialist, like in our practice would be Dr. Dute and Dr. Brian Kim, and our glaucoma specialist to control your eye pressure. It's never, a lot of you guys make it confused. Why do I have to see both doctors so often? They're doing their parts due diligently to control the retina issue to make sure the vessels stop growing from the laser and the injection you're getting. But I'm the one who's monitor your pressure. So when it comes to time when you need the glaucoma surgery, we know how your eye is doing from a pressure and glaucoma standpoint. So it's very important for both of the specialists to take a look at your eye. This is saying what I just told you. Glaucoma specialists manage the eye pressure. We basically at the beginning, if I saw you first, and oftentimes I do, because your optometrist, if they find a high pressure, they may refer you to a high pressure person, a pressure management person, which is glaucoma specialist, to control your pressure. When I see your eye, I realize this is something that's caused by your retina issue. Then what I do at the beginning is to temporize the matter by giving you maximum drops I could give, or even oral medications, to give the retina doctors enough time to do their initial management of the unhealthy vessels, to get your injection, to get your laser in place. That will definitely reduce your risk of bleeding and inflammation during the glaucoma surgery that you eventually will need. So they focus on giving you injection. A lot of people might have gotten a lot of that. And also the PRP laser that you may get. I know Dr. Kim and Dr. Dute often do them in 3 sessions. So you have laser put on the retina to stop the signals that the retina send to the body to recruit new unhealthy vessels. So that treats those problems, basically treats the cause at its root cause by stopping the unhealthy vessels. That will also allow me more room to do my glaucoma surgery. Can it be cured? The unhealthy vessels can often be controlled. with the injection and the laser. Sometimes it may require long-term injection or repeated laser to keep the bleeding and swelling at bay. And eye pressure can oftentimes be controlled with a combination of surgery and drops. We can prevent further loss of your vision or visual field from the high pressure. But like I said, just similar to any other glaucoma, we cannot repair the damage you've already got. So we're basically just preserving what you have. And the underlying issue, like for example, in diabetic retinopathy, is your diabetes. If diabetes is still out of control, you don't work or you haven't been find the best way to control your sugar, then these can very well happen again in your eye and maybe in the other eye as well, or even in the same eye, despite initial better management, it may actually happen again. If your underlying problem is your high blood pressure, your cholesterol issue that caused your vein occlusion, managing those is important to prevent having another one in the same eye or similar situation in the other eye. So yes, the neovascular glaucoma can be managed, but it can never be reversed. And it's not a guarantee that once one episode is treated, it doesn't happen again. It really requires your active participation to manage your other health issue to prevent these bad things happening to your eyes again. So I will, this is our new office location that I wanted to show you and I can take some questions at this point for things that's relevant to the previous two topics I just talked about. And then I can kind of fly through a bunch of maybe 3 more shorter topics that I want to increase your awareness about.
Yeah, thank you so much, Dr. Wong. And yeah, we did recently move at the beginning of 2020. So come on down and visit us at our beautiful new location. Very spacious. We're making sure that we abide by all our COVID protocols, and we have plenty of room. So everybody is very much so separated, and we're doing temperature checks and making sure everybody feels comfortable, given the current circumstances, and still being able to see patients. So coming down and see us. And we do have a couple of questions. And for those who do have questions, please feel free to use the question and answer. Go ahead and type that in there, and we'll be sure to get to it for you. Our first question of the night, Dr. Wong, is what is the suggested protocol for those with active thyroid eye disease with the fat layer buildup due to proptosis, cataracts, and borderline glaucoma all in the same eye?
So that's a great question. So if you have borderline glaucoma, cataract, and thyroid eye diseases all together, all 3 may contribute to your high pressure. I would recommend, depending on where the pressure is and how much damage, which I assume is minimal given its borderline, to address the thyroid eye issue first. If you need any major surgery around the orbit to do decompression, that's usually number 1. So once that's resolved, some thyroid eye disease patient may have eyelid exposure problem and also double vision problem. Those can wait. And then so the decompression is number 1, because that is a physical stress on the optic nerve from the outside in, not related to the pressure from the inside, but more from an outside, like, things squishing onto the optic nerve. That needs to be resolved first. Once that's done, if you don't need it, then don't worry about it. If you need it, do that, and then do the cataract, and if needed, any mixed procedure for your borderline glaucoma. Then after that, we can solve the double vision problem or lid problem that you may be facing.
Awesome. Thank you so much. Is there any evidence to the use of skin lotion or like suntan lotion that can continue to drainage problems of the eye? Like, can that lotion potentially clog the eye if you're getting it near and around the eye?
No, so creams, topical stuff on the surface of the eye or eyeball has not shown any relation to causing glaucoma, any type of glaucoma. Injection on your face in the form of, Botox and other things have shown some evidence, or I should say just few case reports showing that could cause retina issue or glaucoma issue, but not just suntan lotions, no.
Okay, wonderful. And it does look like we have one more question for the time being. And as I say that, another one pops up, which is fantastic. Everybody continue to ask their questions. I've been encouraged to take pills inserted into the eyes to drop the pressure, and no need to take drops for about 2 to 3 years. Any thoughts?
I think you are talking about the Durista eye implant or I would say drug-eluting implant in your eye. That's a newer development. The medication in that implant is similar to the Travatan or Zalatan or Zioptan or Latanoprost. One of those names might ring a bell. That's the same chemical component, but packed into a pellet that's injected into the eye. Its benefit compared to eye drop is that it kind of just sends out drugs to the angle where it's sitting in the angle and send signal or send the medications directly to those cells that needs the medication. It works quite well. And if you are one of those people who don't really want use eye drops, or especially if you have allergy to eye drops, that's a great option for you. And so similar to what I talked about last time in my previous seminar about the SLT laser. And those are all non-invasive ways. I think of it as minimally invasive to cause doesn't really have any major side effect associated to reduce eye pressure. How long does it work? So far, this medication is FDA approved for one-time injection only in each person. How long does it work? It's still a work in progress. We don't know. In some people, it lasts years. In other people, it lasts months. So it's worth trying especially if you're struggling with issues related to using eye drops.
Wonderful. And the person did confirm that it is Durista that they were referring to. So what type of glaucoma can cause low contrast of vision?
All of the glaucoma can cause, because glaucoma causes nerve damage, and one of the symptom of having nerve damage, in addition to visual field loss, which means tunnel vision, is contrast sensitivity loss. So all kinds of glaucoma can.
We have one person who had an extent implants in both eyes recently, one 3 days ago and then one a month ago. The pressure in the eyes is still about the same at about a 14 or a 15. They're taking prednisolone. When could they expect pressures to drop typically, or if does that indicate a failure of surgery by chance?
It's really hard. I would love to provide some insights about any surgical outcomes, but without doing the surgery or even looking at the eye or know how it went, know what the glaucoma was, what the severity was, why the choice of surgery, is really hard to weigh in whether this is a success or failure. But I think you're meaning Xen, Xen, the Xen stent. It's considered one of the bigger MIGS procedure that's done to the eye, oftentimes due to lower eye pressure into the lower teens. So I wish I could tell you what it means at this point, what the pressure is, but I think your surgeon who did the surgery would have a better answer to that question.
Yeah. So it looks like at the time we don't have any more questions of the moment. Was there anything else that you would like to cover in the meantime, Dr. Wong?
Yeah, so I'm just gonna fly through a couple other things. Uveitic glaucoma is another thing that can happen in people with inflammation related to eye pressure. I'd only like to caution you a few things. So inflammation themselves can cause inflammation in the angle, which oftentimes presents as high pressure also. If left undetected or untreated, the high pressure is just the same no matter where it's coming from, similar to your bread and butter open angle glaucoma or acute angle closure glaucoma. It will cause glaucoma similar damage. So if you have an inflammation in the eye, make sure your pressure is also checked. And if it's high, that it's treated. A lot of the times, if the pressure is not extremely high, only borderline high, slightly higher than what we expect with normal, we may not treat it with eye drops and just wait for the inflammation to be treated because that's the cause of the problem. That's possible. But if your pressure is in the 40s as a result of inflammation, it should be treated. And recurrent inflammation can lead to scarring, just like neovascular or angle closure glaucoma can. So make sure if you have inflammation, come back for your follow-ups to make sure you don't have a silent inflammation, that not having too much symptoms that you can notice that's causing you vision, your pressure, and things like that. And for treatment for these inflammation, a lot of you are familiar with the steroid drops. It could be prednisolone that you might be on. Durezol is another one you could be on. You could be on Inveltus. Those are the names for the steroid drops. High doses of these steroid drops and high frequency of using them, which is sometimes unavoidable for those people with uveitis or acute inflammation in the eye, can cause high pressure as well. So even if when you feel your eyes are better, if you have used these drops, make sure you come back for a pressure check and make sure you don't have the secondary, side effects from these medications. So high awareness is definitely warranted to prevent glaucoma damage starting from uveitis. There is a specific category, it's called uveitic glaucoma. So I hope if for you people who may have inflammation in the eye, it's currently on the steroid medication, make sure you have your pressure checked also in your follow-up. And to piggyback that, steroid response is a known thing. It's pretty common. And we often use steroid drops if you didn't have any previous inflammatory episodes. If you had surgery in your eye, most of you have used them. And these steroids may not cause a major problem the first time around when you use it, but if you're ever exposed to it again, you may have a response to the steroid in the form of high pressure. And no matter, like I said it so many times today, no matter where the high pressure is coming from, it does the same thing. It causes glaucoma. And today we received a call from a patient asking a pill that they take, which contains steroid, if that's causing eye pressure. So in fact, steroid in the forms of creams or ointment on your face can increase your risk. Steroid in the forms of nasal spray can carry risk of increase your eye pressure. But steroid in the form of pills or injections into your vein does not typically cause high eye pressure. It may in very rare cases, but 99% of the time, that's not the main culprit to your eye pressure increase. So if you're taking steroid as a form of eye drop, cream on your face around the eye area, especially nasal spray, those are risk factors for you to have a silent high eye pressure in the eye, not knowing, and cause glaucoma. So having eye pressure checked if you're on these medications, also very important. So like I mentioned, for those who have surgery, you may not remember you were exposed to steroid in the past. So when you have your post-operative day 1 visit, and then you may have another one in a week or 3 weeks or a month, you may think your vision's all that better, and it is, but there is still a need for you to come back for your follow-up to make sure your eye pressure stays in the normal range as well, to avoid a problem with chronic glaucoma. So one more thing that some of you may do is to use the leftover steroid drops you may have from your previous flare-ups, either from urgent care or from your eye doctors. Not a good idea. Number one is it may expire. Second, that the steroid use, like I said, you have to have a regular eye exam after you use it to make sure you don't go into a steroid response with high eye pressure. And glaucoma surgery sometimes can cause emergency as well, which is infection related to these procedures. A tube exposure is where some of my patients probably have tube plate in their eye as one of the major glaucoma surgeries. I'm talking about a real glaucoma tube shunt, or called glaucoma drainage implant. These tube, because it's a device, it's an implant sitting underneath your eyelid, with repeated eye blinking, rubbing eye, can cause exposure of this tube. Once that happened, there is literally a wide open pathway from the outside world and the inside eye. So that increases your risk of inflammation and infection. And if that infection happens, it could be very severe if left untreated. That could cost you not only the vision, but the eye themselves as well. So if you know you have a tube in the eye, you need to follow up routinely as well. Number one is because if you had a tube, your glaucoma is probably at least moderate to severe. And number two, if you had a tube, we need to make sure that it doesn't get exposed and cause you infection. Now, those who had micro stents, such as iStent, Hydras, or CyPass is no longer available in the market, do not have this exposure risk because they sit inside the eyeball, not on the surface. So I talked about that already. The reason I want you to have your device checked is because to avoid infection. For you to know you had an infection is vision decreased dramatically, severe pain, pussy discharge, redness of the eye, and also could be increased floaters. And that's usually a more severe stage of it. Some people start with just pain, redness on the surface of the eye and decreased vision. If you have a device in your eye, you know, and when I say device, I mean the glaucoma drainage implant, not your iStent or Hydras, the micro stents you had placed in during cataract surgery. I mean the main glaucoma surgeries. You have to have those checked up if you develop symptoms that could be a sign of infection. And we will have to give you antibiotics, a lot of the time starting as drops or oral medications, or even injections into the front or the back of the eye, depending on the severity of infection, to save your eyeball and vision. And that's all I have for today. Hope that was helpful. Any other additional questions to everything I talked about today?
Yeah, we did have some questions pop up in the meantime, so I'll go ahead and ask those.
Sure.
Speaking of drops, how often can drops be used each day before there's any sort of inflammation associated with it?
Is this, you mean glaucoma drops? What kind of
Glaucoma drops, correct.
So glaucoma drops, it's a strict dosage. You're not supposed to use it as you want to. Most of them are once at night, twice a day, or at most 3 times a day. Use them as directed. All of these medications contain preservatives in them unless they are preservative-free glaucoma drops. Those are less irritating or inflammation, prone to inflammation. So, but they're also more expensive. If you don't need them, you don't necessarily have to use them to prevent certain things from happening. And so just use them as directed. One word of caution is for those who only use the ones at night, your Rocklatan, your Ropressa, your latanoprost, Zalatan, Travatan, Travoprost, Zalprost. Those medications, once at night is strictly once at night. If you use that more than once a day or within 24 hours, it causes you more harm than benefit. So do not use it more. Not more is not, better in this situation. And use lubricants in between your drops, throughout the day. Use artificial tears like Refresh, Sustain, Genteel, those good things that you can just buy over the counter. Is always good to soothe the inflammation or irritation on the surface of the eye if you have to use a lot of glaucoma drops.
Awesome. Are there any side effects from using dexamethasone for orally long term?
If we're only talking about oral steroid pills and its relation to eye problems, no. 99% of the time it does not cause eye problems, but taking steroid long term causes you other systemic things. Your mood might be different. You may have more pimples and things like that, but that's kind of out of the scope of my talk or ophthalmology in general. You may want to talk to your primary care doctor about those side effects if you have any. But if you're only talking about the eye, it does not cause any direct damage to your eye if you're taking it as a pill.
In general, are lutein and zeaxanthin good vitamin supplements?
Those are two active ingredients in your AREDS2 or eye vitamin in general. Those are the clinical studies only show that these are beneficial if you have certain types of macular degeneration. No direct benefit proof for glaucoma or any other eye diseases, including cataract.
All right, and it looks like we have one last one, and that is, does taking niacin for cardiovascular health affect the vessels in the eyes and angle closure? This person happens to feel flush in the eyes. Is there any correlation due to that?
No, I think niacin is known to cause flushing sensation throughout the body. So I don't think and redness and things like that. I don't think it's not known to cause any glaucoma or eye related problems. But niacin does give you like a whole body sensation of redness and flushing.
Awesome. And we had one more that popped up in the meantime, and that was this particular person was told that they cannot have orbit decompression surgery until their TED stabilizes. Meanwhile, significant contrast vision loss is occurring still. Would you recommend Tepezza to lessen the glaucoma pressure?
It depends on what the pressure is. It's very hard to give advices like this to a specific situation. I hope you, whoever is asking this medication, this question, sir or ma'am, you can understand. It's very hard to judge because the decision about what to do with pressure all depends on how severe the problem is and what medication you're on and what we're trying to achieve. It is true that if your thyroid eye disease is not stable, orbit decompression is not guaranteed to have a success because it's still ever changing. So once it's stabilized, then they'll do the problem. So if your pressure is high, then the general advice is yes, you have to use some eye drop to control eye pressure. But if your pressure is not high enough, then I don't know when you mean contrast sensitivity, it's not necessarily from glaucoma. It's actually probably from the compression on the nerve from the outside, and that using eye drops is not going to resolve.
Wonderful. Well, thank you, Dr. Wong. Looks like it is the rest of the questions that we have today. And if anybody does have any additional questions, you can always contact us. We are here to help, and we are here to answer your questions and make sure you feel as comfortable with your vision as possible here with Harvard Eye. So we appreciate that. You can always reach out to us, and we're happy to put you in contact with whoever. You can email us at marketing@harvardeye.com, and we'll be sure to address your questions there and to get you into the right hands with those who are able to answer your questions the very best. So with that, we can go ahead and conclude tonight's evening. First and foremost, I want to thank you all for joining our webinar. I obviously want to thank Dr. Wong for the wonderful presentation and giving us her time tonight. I mentioned if you do have any questions, feel free to email us. That is marketing@harvardeye.com. We'll be happy to address your questions there. But without further ado, on behalf of Dr. Wong, myself, and everybody at Harvard Eye, we appreciate you for joining us this evening and hope you have a wonderful rest of your night.
Yeah, thank you all for coming. All of our webinars, mine and other doctors, are all recorded. So I think there's a YouTube link that will be sent out to you guys. If you want to watch it again or watch any of the previous ones, you're more than welcome to. And any questions, like Michael said, just send them in. We'll try to answer them as best as we could.
Thank you so much, everybody. Have a great rest of your night.
Good night.